Okay, this is part 2 of chapter 2. So the alternative definition. Basically, we've got that definition that's very hard to use because it's so subjective. But we're also recognizing that we have to look at the culture, we have to look at age-appropriate behaviors, we have to look at norms, and we also have to look at the effects that the educational environment, the school environment, has had on precipitating the characteristics of EBD, as well as family kinds of dynamics that contribute to EBD. Then we also start talking about psychosis, medical diagnoses, that includes schizophrenia, conduct disorder, affective disorders, anxiety, depression. So those are all medical diagnoses. So we're really starting to look at the whole picture of students. But what we're recognizing is that we have to look at the whole child. And that's hard for schools to do. And it's hard for teachers to do. And we need training to do it. We cannot do this by ourselves. We cannot determine how to reach these children. We cannot design instruction alone. We need a team to help us with this. So, if nothing else in this course, you should not be alone. Always remember, you're not alone in this. This has to be a collaborative effort to make sure that our children are maximizing their potential. And I feel very strongly about that, obviously. So let's look at these. Some disorders are not acceptable in any culture. No matter what community a child lives in, there are norms there, whether the child is inner city, whether the child is involved in a situation where his or her parents are unemployed, where they don't have food to eat, whatever, if they're in a suburban school that is wealthier, where drugs are abundant. We have to take all of these considerations in when we are identifying children and providing services for them. And we talk about covert behavior. And covert behaviors are, what's going on inside of the child. And that's really tough. We can't see a lot of this. We can't see the depression. We can't see suicidal tendencies. We can't see anxiety. And that puts us at a disadvantage. So we have these externalizing and internalizing kinds of behaviors. A lot of children that are diagnosed or that are identified with these kinds of mental health issues, sometimes we can see them, but sometimes we can't, and most often we can't. So we need to rely on the medical personnel so that we can team up the educational model and the medical model to help the child and bring in the family. Why are we reluctant to label? Already talked about it. It's very stigmatizing. Nobody wants to be considered having a mental health issue. Very, very stigmatizing. And what's difficult about it is that it's familial. So what I mean by that is, by saying that is, there are certain disabilities that we can see. And we have a comfort level with that. If somebody's in a wheelchair, we know they have a physical disability. If someone is Down syndrome, we see it. We see the features of Down syndrome. But we can't see emotional and behavioral disturbance. We can't see learning disabilities. We can't see ADHD by looking at the child's face. All we can see is the behaviors that the child demonstrates. So that's tough for us. It's much easier when we can see the disability than when we can't see it, because we never know what to expect. And that's where the assessment comes in, and that's where the individualized program of supports and accommodations comes in. Many schools choose to classify children multiply disabled because they look at the learning difficulties as well. And that's very important because this whole time we've been talking about the importance of the instructional program. When children have academic deficits, it's great because we can, if we classify a child multiply disabled, it just means that we are providing supports and services for both disabilities. So if the child has EBD, we provide counseling services, we provide social skills. Then we do a behavior intervention plan. And if the child has learning disabilities, we do special ed, we do in-class support, we do pull-out. So we are meeting the needs of both disabilities. Therefore, we can classify the child MD, which is much more acceptable to parents. That they'll take. When we consider the numbers of students with EBD, we find that as a disability, it is under-identified. And why is that? We just talked about it. Because of these issues. And a lot of schools are reluctant to identify a child EBD because they're difficult, the teachers aren't trained usually, and the worst part of it is that the idea is that they're going to wind up in juvenile detention anyway, so why waste the money when we could be paying for our gifted and talented students? And believe me, as a former director of special ed, a lot of times that was said to me. I heard that a lot. These videos are on here. The last two are pretty informational, but they're pretty redundant as well. I put them on here because they are in the textbook, so I gave you the links to them if you're interested and if you have any questions. But your group is assigned to do this for this recording is explain the reasons that we are resistant to consider EBD as a disability, and ask a question about the content, and also read the case study of Alan Zook, pages 51 to 52, and in your groups answer the 4 questions. Make sure you record it, and then I will respond. Thank you.